Good morning, everyone. We'll just be waiting a couple of minutes to get started. Good morning. Thank you for joining. We'll be getting started in just a few minutes. Good morning. Greetings from all around the world. We'll be starting in just a couple of minutes. Good morning. Greetings. We'll be starting in just another minute. Welcome to today's webinar. My name is Megan Spencer, and I am Country Manager US for NextMune. NextMune is a science-driven, global, specialty pharma company dedicated to improving health for dogs, cats, and horses. We are a proud partner of Biogal. Biogal is a well-known manufacturer of veterinary diagnostic tools. Biogal has developed many small animal infectious disease detection product lines, all of which can be performed and analyzed from the comfort of the veterinarian's own clinic or lab. Biogal's products are supplied to more than 50 countries around the world, and they support their partners with educational tools and the latest veterinary updates. You can learn more about their products on biogal.com. Today, Professor Dr. Mary Marcondes will be presenting a webinar on Biogal's vaccine titer testing product known as VacciCheck. I personally am very excited to learn more about VacciCheck and her recommendations regarding the incorporation of VacciCheck into your clinic's standard of care. Professor Mary Marcondes qualified as a veterinarian from the University of Sao Paulo, completed her Master's of Science in Clinical Veterinary Science at Sao Paulo State University, and her PhD in Clinical Veterinary Science at USP. Mary retired from the School of Veterinary Medicine at Sao Paulo State University as an associate professor of small animal internal medicine and infectious diseases in 2018. Currently, she is a member of the WSAVA Vaccination Guidelines Group, the co-chair of the WSAVA Scientific Committee, a member of the African Small Companion Animal Network Board, and a member of the Companion Vector-Borne Diseases World Forum. Webinar participants today are welcome to type any questions in the Q&A area on your screen. I will present a few questions to Dr. Marcondes at the end of her presentation. The rest of the questions will be answered via direct message or email. And now, please welcome Dr. Mary Marcondes.
Thank you, Megan. So let's start to talk about vaccination and standard of care using titer testing. Vaccination is an important and fundamental part of veterinary practice. However, in recent years, there has been a shift away from the concept that pets make a yearly visit to the veterinarian for a vaccine booster to what we call a preventive annual health check visit. and vaccination should be delivered as one part of this visit. Unfortunately, many clients believe that vaccination is the most important reason for annual veterinary visits. During the annual health check visit, practitioners should evaluate the animal body score, talk about nutrition. We should emphasize the importance of ecto and endoparasites control. Also, during this consultation, we can use point-of-care diagnostic tests for infectious diseases that are important in that area. It is important to address the necessity of dental care. We can talk about behavior problems, explain that geriatric patients and patients with chronic diseases will need more frequent consultations. And finally, during annual health checks, clinicians should assess the need for core and non-core vaccines for that particular year. This visit may still involve administration of selected non-core vaccines, which should be given annually, as the duration of immunity for these products is generally 1 year. But an animal might not receive core vaccines every single year. And to help in the decision of whether a dog or a cat should be revaccinated with core vaccines in this year, the use of titer testing kits should be part of the annual health check visit. Pets should not receive a vaccine booster that contains as many antigenic components as possible, and the same vaccination protocol should not be applied to every dog and cat that visits the practice. Vaccination protocols should be personalized according to the requirements of the pet, carried out after careful assessment of the risk factors based on lifestyle, geographic area of residence, age, and previous vaccination history. The range of companion animal vaccines has expanded considerably and includes novel types of vaccines apart from the conventional modified live and inactivated vaccines, such as subunit vaccines, recombinant vector vaccines, and DNA vaccines. We are going to talk about 2 types of vaccines. Modified live vaccines contain a live but attenuated whole organism that can infect cells and replicate within them, establishing a low level and transient infection that promotes a strong immune response without causing disease. They are generally more immunogenic, can induce both humoral and cellular immunity, should require fewer doses to achieve the desired response, and may generate a consistent and lasting immune response for many years, if not for life, after a single dose without the need for revaccination. Examples are vaccines against canine distemper virus, canine adenovirus, canine parvovirus, and feline parvovirus. An inactivated or killed vaccine contains entire inactivated antigenically intact microorganisms that are not able to infect or replicate, but are able to stimulate an immune response. They usually produce less potent immune responses and may require an adjuvant and usually multiple doses, even in adults, to stimulate an adequate immune response. Most inactivated vaccines require at least 2 initial doses to immunize, regardless of the dog's age. The first dose generally primes the immune response, and the second provides the protective immune response. Inactivated vaccines usually have a shorter duration of immunity when compared to modified live vaccines, and they need more frequent boosters to maintain immunologic protection and memory. As examples, we have Leptospira, Bordetella bronchiseptica, and rabies vaccines. Rabies vaccine is an exception since it is highly immunogenic and can induce protective immunity with a single dose. To reduce the unnecessary administration of vaccine antigens to dogs and cats, vaccines can be classified as core, non-core, and not recommended. A core vaccine is one which every dog or cat, no matter where or how they live, should receive because it protects that animal against infectious diseases which may be lethal or cause high morbidity. Rabies vaccine is considered core in any country in which the disease is endemic. In contrast, the choice of giving a non-core vaccine should be based on consideration of the geographic prevalence of infection, the lifestyle of the individual pet, and the risk for that animal to become infected. Not recommended vaccines are those that don't have sufficient scientific evidence to justify their use. The core vaccines for dogs are those that protect against canine distemper virus, canine adenovirus, and canine parvovirus, and rabies in endemic countries. Non-core vaccines for dogs are those against Bordetella bronchiseptica, canine parainfluenza virus, leptospirosis, and in more restricted geographic areas, vaccines against Borrelia burgdorferi, canine influenza virus, and Leishmania infantum. The core vaccines for cats are those that protect against feline parvovirus, feline herpes virus, feline calicivirus, and rabies in any country where the disease is endemic. Non-core vaccines for cats include those that protect against feline leukemia virus, Chlamydia felis, and Bordetella bronchiseptica. The vaccine against feline immunodeficiency virus is variably classified as non-core or not recommended, depending on the guidelines. Before we talk about vaccination protocols, let's discuss a little bit about maternal immunity. Maternally-derived antibodies are important to protect puppies and kittens in the first weeks of life, but they also interfere with the ability of the neonate to mount its own protective immune response to most core vaccines. Serum MDA inhibits immunoglobulin production within the neonate and prevents vaccine antigens from stimulating an immune response. Let's imagine that this is a graphic of an immune response for a specific disease. And 80 is the minimal antibody level to protect the dog against this disease, while 10 is the minimal antibody level that interferes with the vaccination. This means that while the puppy has an antibody level above 10 for this disease, he will not develop an immunological response when vaccinated. In most puppies and kittens, maternal-derived antibodies decline to a level where it is already possible to get a response to a vaccination in about 8 to 12 weeks. However, a small percentage of pups and kittens may still have maternal antibodies above this level around 14 to 16 weeks of age. That is what is happening in this graphic. During the period when MDA are insufficient to provide complete immunologic protection, but still enough to block the endogenous immune response, known as the window of susceptibility, a puppy or a kitten can become infected if it comes into contact with the pathogen. It is not possible to predict when this window occurs, as the amount of MDA transferred will vary between liters and within liters for individual neonates. As it is not possible to predict the exact moment of loss of MDA, the initial core vaccination series with modified live virus vaccines usually requires the administration of multiple doses. These are not booster doses. They are applied to trigger a primary immune response as soon as possible after the MDA has dropped. Core vaccination must start at 6 to 8 weeks of age, with subsequent doses given every 2 to 4 weeks until 16 weeks or older. The 2-week interval should be carried out in environments likely to be heavily contaminated, such as shelters or breeding kennels. So in this situation here, the vaccine applied at 6 weeks does not elicit an immune response. The same at 10 weeks. But now at 14 weeks, MDA is below the minimum level that can block an immune response, so the dog starts to produce antibodies. In this other situation, MDA stays above the interfering level until 16 weeks of age. So vaccines given at 6, 10, and 14 weeks of age are not able to elicit an immune response. But a vaccine given at 16 weeks of age will elicit an immune response. In the absence of MDA, a single dose of core modified live virus vaccine provides adequate and robust immunity. So the most important dose is that administered at 16 weeks of age or older, when almost all puppies must have already lost MDA, being able to respond to the vaccine. Even with the administration of the last dose of vaccine at 16 weeks of age, a small percentage of puppies and kittens may not respond effectively to vaccination. The same considerations related to MDA apply to kittens as to puppies. As an example, if a puppy starts core vaccination at 6 weeks, has a second dose at 10 weeks, and a third dose at 14 weeks, he will need to receive one more dose at 16 weeks or more. After the initial series of core vaccinations, it was recommended to administer another set of core vaccines at 12 months of age. The purpose of this vaccine is not to boost the immune system, but to ensure the development of a protective immune response in any dog or cat that may not have responded to primary core vaccines. However, with this protocol, a puppy that fails to respond to any of the core primary vaccinations will be left unprotected until receiving this vaccine at 12 months of age. For this reason, the WSAVA vaccination guidelines group suggests that veterinarians try to reduce this possible period of susceptibility by moving this vaccine from 52 to 26 weeks of age. In this other situation, starting at 8 weeks of age, with a second dose at 12 weeks and a third dose at 16 weeks, the puppy should just receive another vaccine at 6 months of age. Therefore, the number of primary vaccinations will be determined by the age at which the first vaccination is initiated and the interval selected between vaccinations. An adult dog or a puppy over 6 months of age that were never vaccinated require only a single dose of core modified live vaccines to generate a protective immune response, since they don't have maternal antibodies to block this response. Dogs that responded to vaccination with core vaccines containing modified live virus maintain solid immunity for several years in the absence of any repeat vaccination. Therefore, after vaccination at 6 months, subsequent revaccination should be administered at 3-year interval. The same protocol should be applied for feline parvovirus vaccine. Cats older than 6 months need only 1 dose of modified live virus parenteral parvovirus vaccine. However, they need to receive 2 doses of feline calicivirus and feline herpes virus vaccines to be immunized. Unlike feline parvovirus vaccines, which induce a long-lasting complete protection, feline herpes virus and feline calicivirus vaccines can reduce clinical signs, but do not provide complete protection. Revaccination against respiratory virus should be determined by the risk of exposure of the individual cat. A low-risk cat, for instance, a solitary indoor animal that does not visit catteries, might safely be vaccinated triennially, while a high-risk cat should receive an annual vaccine against the upper respiratory virus components. So, how can I know that my patient is protected? For many vaccines that we use, there is a very strong association between the presence of antibodies and protection. We can measure antibodies to find out if the animal is protected. This correlation is very strong for the infections we can see listed on this slide: canine distemper, parvovirus, and adenovirus, and for feline parvovirus. So much so that we can say that if an animal has these antibodies in their blood, they will be protected. But this doesn't happen to all vaccines. We are talking specifically about those infectious agents that we have just mentioned. If we look, for example, at a vaccine against leptospira, we know that the vaccine will protect an animal for 12 months. But we also know that when we give a vaccine, it will induce a spike of antibodies against leptospira that will rapidly decline within a few months. During this 12-month period of protection, the animal may have very low titers of antibodies or even be seronegative, but the animal is still protected if the antibody is not there. In this case, there is not a strong correlation at all between leptospira antibodies and protection. There are many studies that have been done that show that dogs vaccinated with modified live core vaccines are protected for quite long periods of time. This is a study from Dr. Ronald Schultz that showed that in an experimental setting, you can take puppies properly vaccinated and detect protective antibodies for 10 to 14 years after vaccination, even without annual or triennial core revaccination. These antibodies provide an indication of protection. This was a study performed in Australia that involved almost 250 dogs. Professor Michael Day was one of the authors, and the study shows us the protection against 3 core diseases for the dogs. These dogs here were last vaccinated anytime previously between 1.5 years to 9 years. And more than 96.6% of them still had antibodies against core vaccine components. There are some studies in cats as well that show that cats vaccinated with modified live core vaccines are protected for quite long periods of time. In this study, with 272 cats older than 2 years that were last vaccinated up to 4 years previously, high levels of protective antibodies against feline parvovirus were found in almost 97% of the cats. In this particular study, there was also evidence of antibodies against calicivirus and herpes virus. But as I said before, that correlation is not very strong between the presence of antibodies and protection against those two diseases. And how do we measure the presence or the amount of protective antibodies against infectious agents like canine distemper, adenovirus, and parvovirus, and feline parvovirus in the blood of dogs and cats? We were able to do this for decades using the gold standard tests, which are virus neutralization tests, most often used to detect antibodies against distemper and adenovirus in dogs, and the hemagglutination inhibition test for antibodies against canine and feline parvovirus. Let's talk a little bit about the concept of titer. A titer simply is a measure of the quantity of antibody present in a serum sample from a dog or a cat against the antigen that you are interested in. It is a way of measuring the amount of antibody that's present. Actually, the formal definition of titer is the reciprocal of the highest dilution of serum that gives a positive reaction in a serological test. In order to determine the titer, what we normally do is a dilution series of a serum sample. And what you are looking for is the last test tube in the series of dilution that gives you a positive result for the presence of antibodies. So here we got two serum samples from two different dogs, and dog A has a titer of 256, while dog B has a titer of 16. However, as Professor Marcondes always used to say, a titer is not a magical number. When it comes to serological testing for infectious diseases, some people think that unless the dog has this particular number, it hasn't got enough antibodies and is not protected. And that's not the case. The titer defines a range and not a specific number. If we say that we have a titer of 320, that means that somewhere within the range of one tube at each side of that reaction, which are 160 and 640, is the actual point where that antibody will run out. So the titer is quite a wide range and is not a fixed number. And that's the reason why when it comes to serological testing, the WSAVA vaccination guidelines group tends not to refer to a specific protective titer in absolute numbers. And we consider that a seropositive dog or cat is protected and a seronegative may not be protected. It is not the titer that concerns us, but is the negativity or positivity of the test. Not so long ago, if you wanted to determine whether a dog had protective antibodies against distemper, for instance, you had to get a blood sample and send it to a virology laboratory to perform a virus neutralization test, and probably a couple of months later receive the result back. But what has really changed in the last 2 decades, and depending on the country less than that, has been the ability to veterinarians to run this type of testing in their own practices. We now have several in-house test kits that enable us to do this sort of test. It is important to choose tests that have been present in the market for a certain amount of time and with independent scientific publications validating the test. You might be able to buy any test, But is it a good test? In my opinion, what makes a good test is independent, peer-reviewed evaluation on scientific publication in the literature. The advantages of these kits are that they are simple to run, they are quick, you have your results in around 20 to 30 minutes rather than a couple of months. They are not that expensive, but unfortunately, they are still more expensive than giving a vaccine. However, good science or good clinical practice tells us that if we have a test to use to determine whether we need or not to give a vaccine, we would do the test and then make the decision based on the test result. Those tests are validated against the gold standards for each pathogen and are available for canine distemper virus, canine adenovirus, canine parvovirus, and feline parvovirus. There are tests in some markets that can detect also feline calicivirus and feline herpes virus antibodies. However, we discussed a little while ago that there is a strong correlation between antibodies and protective immunity of feline parvovirus, but the stronger correlation for calicivirus and herpes virus is with mucosal and cell-mediated immune response. Because of this, in some markets, there is a move now to removing the feline herpes virus and calicivirus components from the feline titer test, since the correlation is not so strong, leaving just the feline parvovirus component. We have talked about the importance of independent validation of these tests. In this particular study, evaluating the immunocomp feline VacciCheck in shelter cats, the specificity for feline parvovirus was 99%. However, the sensitivity was 49%, which was not as good as we would like. But then I will show you another study where the sensitivity was much, much better. In this study, authors evaluated the sensitivity and specificity of the same immunocomp feline VacciCheck for feline parvovirus in almost 350 cats for 3 different HI titer cutoff points. And the results were actually good in comparison to the HI test, with a sensitivity varying from 79% to 87%, and a specificity varying from 81% to 89%, depending on the HI cutoff points. This is a population study published by Professor Michael Day using the VacciCheck test kit. And it was a study of almost 500 dogs coming into veterinary practices in the UK that were using the test for a number of years. In this population, many of the dogs were on a triennial core revaccination program, but some of them have not been vaccinated for a long period of time, including dogs that were vaccinated 10 years before. And what the study showed, using a yes or no answer, without looking at the semi-quantitative scores, is that almost 94% of the dogs were seropositive for canine distemper, canine adenovirus, and canine parvovirus. And this shows us that the protocol that UK vets are using, switching from 1 year to 3-year revaccinating programs, is still providing a high level of herd immunity against core diseases. So, when will you consider using those in-house titer testing kits? The first situation is how to know if a puppy or a kitten in early life has actually responded to the core vaccines. I gave this puppy a vaccine at 8, 12, and 16 weeks of age, and how do I know that it is protected? We can now know the answer by performing a titer test 4 weeks after the last vaccine dose. In this case, at 20 weeks of age, we will test to see if the puppy has antibodies against distemper, adenovirus, and parvovirus. At 20 weeks old, it would be highly unlikely that this pup has still antibodies that has come from the mother. If this puppy is protected for the 3 antigens, you don't need to give the last vaccine at 26 weeks of age. Let's think of a puppy that you have given the core vaccination ending at 16 weeks or later. You should test it 4 weeks after the last dose. If this puppy is seropositive for the 3 components, then it could be now revaccinated every 3 years. If this puppy is seronegative, you will have to revaccinate it again at 26 weeks. You might want to switch brands of vaccine, but actually there is not much point in doing this because in terms of core vaccines, they are very similar between manufacturers. And then wait 4 weeks and repeat serology. If the puppy now is seropositive, it can be revaccinated every 3 years. If for some reason this puppy is still negative, and it may be probably seronegative just to one component, not to all 3 of them, it might be distemper or parvovirus, for example, then that puppy may belong to a very small group of animals that we call either low or non-responders. There are some animals that simply lack the right immunological machinery to be able to make a protective immune response to particular antigens. They don't have the right molecules to be able to respond to a parvovirus vaccine or a distemper virus vaccine, for example. And they will never be able to do that, no matter how many times you vaccinate them. Some of those animals might still have some cell-mediated protection, but some of them might truly be not protected at all. Here's another situation where you might consider using a dose test kits. An animal that has been adopted from the streets and you have no idea of the history of vaccination. How do I vaccinate it? You could just vaccinate the dog with core vaccines, but that might be not necessary. What you can do in this situation is simply do a serological test. Chances are that the animal was vaccinated before it was lost and adopted. It might have also natural immunity. So you can test, and if that animal is seropositive, actually it is protected and it doesn't need to be vaccinated and can start the triennial program, If it is seronegative, then you could give him 1 dose of modified live core vaccines, since there will be no interference of maternal antibodies, and the dog responds with just 1 dose. Note that we are talking about core vaccines. If this dog needs, for example, a leptospira vaccine, it has to be treated like a puppy, which means that it will need 2 doses of vaccine to mount a protective immune response. This dog here is Maggie, a miniature schnauzer that belonged to me. And of course, being a dog from a vet, she had a type 1 hypersensitivity reaction when she was vaccinated at 6 years of age. And this is Luna, a German Spitz from a really close friend of mine that had an immune-mediated thrombocytopenia 2 weeks after her core vaccination when she was 4 years old. We are quite sure that the vaccine may have triggered the immune-mediated disease. What do you think has happened to both of them when they had to receive their booster vaccine? Do you think I assumed the risk and vaccinated them again? Or I just decided to avoid any vaccine for the rest of their lives without knowing if they were or not protected? I had an option, and this option was to test them to find out if they had protective antibodies, at least for the core components of a vaccine. Maggie never received a vaccine again and was seropositive for distemper, adenovirus, and parvovirus until she was 14 years old when she died. Luna is seropositive for the 3 components since she was 4, and now she's almost 10 years old. We could use serologic testing every 3 years or even every year as part of the annual health check visit instead of vaccinating dogs. These tests can help making fundamental decisions about whether or not I'm going to revaccinate this adult dog. Maybe 10 or 15 years ago, we used to give every dog every vaccine every year. Unfortunately, this still happens in some countries, especially in Latin America. But then we moved to give core vaccines every 3 years. And now we are moving ahead of this. And we have the option of not just giving core vaccines every 3 years, but we can do a serological test. And if the dog is seropositive, it is still protected and it doesn't need that core vaccine at that moment. What the VGG recommends is that for geriatric dogs and cats, we should do serological testing every year rather than every 3 years. There is this thing called immunosenescence, which means basically that when you get older, your immune system doesn't function as well as it should do, so it makes sense to test geriatric dogs annually. There are many owners that prefer to test their pets than giving a vaccine, and this is happening in Europe and North America. In some countries, you cannot bring your dog to a boarding kennel or a dog show unless it has been vaccinated with core vaccines every year. This is also starting to change. Professor Michael Day has worked with the Danish Kennel Club, and since 2017, they started to accept a positive titer test for core components at their events and not just a vaccination certificate as they used to do. One of the most valuable applications of in-house serology has been in the management of infectious disease outbreaks in shelters, specifically for distemper, parvovirus, canine parvovirus, and feline parvovirus outbreaks. In the face of a disease outbreak, all animals currently resident within the shelter should be tested. Those that are seropositive are protected and will not become infected or die. This protected population should be separated from low or negative responder animals that should be isolated and vaccinated. The susceptible population should not be adopted out of the shelter until after at least 2 weeks for canine or feline parvovirus, or until after at least 6 weeks for canine distemper virus. The susceptible population might be retested after these intervals. The second population to be considered are those animals that are wishing to enter the shelter. They should also be tested before considering admission. Seropositive animals may enter as they are protected from disease. Seronegative animals should be vaccinated and then ideally sent to foster homes and not allowed to enter the shelter until they have seroconverted, when retested after a few weeks later. So, messages to take home. Currently available in-house titer test kits should be selected on the basis of independent, peer-reviewed, published validation. In-house titer test kits play an increasing role in vaccination practice under the annual health check visit. And finally, in-house titer test kits play an important role in shelter medicine. This webinar is dedicated to the memory of Professor Marcondes, who was a member of the Vaccination Guidelines Group from 2006 to 2008, and the chairman of the group from 2009 until 2020, when he passed away. Thank you very much.
Thank you, Dr. Marcondes. That was very, very excellent presentation. We do have a few questions from the Q&A that we're going to go through. The very, very first question is, when the vaccine is given and there is still enough MDA, does the vaccination have any effect on the immune system? They stated, I have been told that although there is not a direct immune response, the immune system still benefits and it makes the next vaccination more successful.
Thank you, Megan, and thank you for the question. Actually not. If you still have MDA and if you give a vaccine like modified live virus vaccine for canine distemper parvovirus, for instance, but you still have MDA, this MDA is going to block this immune response from the vaccine and the immune system doesn't benefit. It's important to know that every time that you give a modified live virus vaccine, it just needs one dose to get an immune response. So you don't need to give more doses. If you are dealing with a killed vaccine, and then you will need 2 doses. If you still have MDA to one of those antigens, it's not worth giving the vaccine. It's not going to change the immune system. So when you have MDA, giving a vaccine is not going to have any benefit. The problem is we don't know when MDA is going to drop to a level that the dog is going to respond. That's why we give so many vaccine doses, because we don't know the exact moment where this MDA is going to drop to a level that will allow the dog to have, or the kitten to have an immune response.
Thank you, that makes sense. The next question is it applicable to vaccinate a dog every 2 weeks for a total of 6 sessions?
Thank you for this question. It's really important. We usually don't recommend to vaccinate puppies or kittens every 2 weeks unless they are on a highly contaminated environments, such as shelters or breeding kennels. Usually, if it's a client-owned puppy or kitten, we don't recommend every 2 weeks. We usually recommend that the vaccination is given every 3 or 4 weeks until 16 weeks of age or a little bit over it.
The next question is related to the WSAVA or the WSAVA guidelines. So it says, are the 2016 WSAVA guidelines the most current guidelines issued?
Okay, thank you. Yes, it is, but it's just for a few months, a couple of months, we think. We are working on the last guidelines. We are finishing it. And we think by the middle of the year, we will have it published. So you will have the last version probably in a couple of months.
Thank you. And the best place for them to find the updated guidelines would be on
it's on the website. Sorry, it's on wsava.org website. if you look at committees, and then you will find the vaccination guidelines group, and the document will be there and will be translated into many languages.
Thank you. We have two more questions. What is your opinion about titer testing puppies before they are vaccinated?
Thank you for this question. It's really interesting. The fact is that we don't want to get blood samples all the time on puppies. So it doesn't make sense to test them, because what you need to have in your mind is that when you're talking about MDA, and MDA is going to drop in a few weeks, MDA for different antigens, these antibodies, they drop in different times. So you may have a puppy, for instance, that has no antibodies against, maternal antibodies against distemper, but it may have still antibodies against parvovirus. So it makes no sense to keep collecting blood samples from a puppy, for instance, every 2 weeks or 3 weeks to find out the exact time when to vaccinate them. So what we don't recommend doing titer testing before vaccinating them. What we recommend is after the last dose, if you can, do a titer testing, wait 4 weeks and do a titer testing. This will be the best option to know, especially to know if this dog or puppy or kitten, responded to the vaccine.
The final question is, after 16 weeks, if there is no response to the vaccine, should we wait 6 weeks to give another vaccine, or is that too long to wait for the puppy unprotected?
Oh, this is a great question. The vaccination guidelines group recommends that we give the last dose at 6 months of age, and we consider this the last puppy dose or the last kitten dose, because we think or we believe that at 6 months or 26 weeks, there's not maternal antibody left. So you can vaccinate this animal and be sure that this vaccine will not be blocked. But let's say that you did your last vaccination at 16 weeks, you wait 4 weeks and you do this serotesting. If this dog is seronegative for any of the antigens, because usually they are not seronegative for all of them, but if it's seronegative for any of this antigen, you don't have to wait until 6 months. You can give this vaccine as soon as possible, and then retest this dog again. So the recommendation is if it is seronegative, you don't have to wait. You can vaccinate it as soon as possible and see if then it's going to be responsive.
Thank you. We do want to squeak in one more last question. It says, for a cat with a year late of vaccines and apparently positive for panleukopenia, when is the best time to test for the antibody post-recovery?
Thank you for the question. Well, a cat that actually was infected from a parvovirus will have an immunity for its whole life. So actually, if you are sure that this cat had panleukopenia, you don't need to test it anymore, because probably he will keep antibodies for the rest of his life. So you don't need to do this. You don't need to worry about it. It's the same when we think about distemper and canine parvovirus. Their immunity is life-lasting.
Okay, and I do think that we have time for just one last question. The question is, what decision should I make if I got a weak positive titer in regards to repeating the vaccine?
Okay, well, thank you for this question. As I said before, and the vaccination guidelines group always thought this way, especially Professor Michael Day, that was our chairman, that if the dog has a positive titer, it is protected and you don't need to worry about this. But we know that, for instance, if you are working with VacciCheck and you get a low titer, you see that this response is not so high, and you are worried about this dog or cat. If you want to vaccinate it, it's okay to vaccinate. You know, like we understand that sometimes vets are concerned about a low titer testing, so they decide to vaccinate. It's okay, but scientifically talking, we understand, or we agree, we believe that this animal doesn't need a booster, because if it has antibodies against those diseases, it is protected.
Thank you very much. Dr. Marcondes, I really feel like you did an amazing job explaining the importance of titer testing. I definitely came away with some new pieces of information. We'd like to thank all the attendees for joining us. We're confident that you learned as much as we did. Certificates of attendance will be sent in a few days. If any attendees have additional questions regarding Biogal or their products or this presentation, you may contact them via info@biogal.com. Their experts are always available to help. There are 2 upcoming Biogal webinars, one on June 7th at 10 a.m. Eastern, titled Diagnostics Matter, Canine Parvovirus Infection Management, with Professor Nicola De Caro, and then another on July 6th at 10 a.m. Eastern, titled Tick-Borne Diseases, with Dr. Michael Lapping. So thank you everyone again for your attendance and your attention. We really appreciate everybody coming onto the webinar.
Thank you.
Bye-bye.
Bye-bye.